to the chat where you're from, who you are, and we'll give a few minutes for everyone to join in. Next slide. So I just want to read this disclaimer. The contents of this video are for informational purposes only and are not a substitute for professional medical advice, diagnosis, or treatment. Please always seek the advice of your physician or other qualified healthcare provider with any questions you have regarding a medical condition. And before undertaking any diet, dietary supplement, exercise, or other health program, neither AIHM or featured practitioners are responsible for any adverse effects resulting from your use of or reliance on any information contained in any video. So for those of you who don't know us, maybe this is your first time attending an AIHM Wellness webinar. The Academy of Integrative Health and Medicine is a global interprofessional integrative health association working together to transform healthcare, body, mind, spirit, community, and planet. And we truly hope that you join the collective integrative health community. Our roots come from decades and decades of holistic physicians and other integrative providers from the American Holistic Medicine Association and ABIHM, and together we are moving everyone forward, and we're just so excited to have you all here together. Next. So today it is really my pleasure to introduce a phenomenal educator, doctor, and just human being, Dr. Erika Cappelluti. Dr. Cappelluti is board certified in internal medicine, pulmonary disease, critical care, and integrative medicine. She was the resident and chief resident and fellow at the UMass Medical Center in Worcester, Mass, and then joined Starling Physicians in 2004 in Connecticut. She was an ABIHM diplomate and an ABIM, now diplomate, for integrative medicine. She's the founder and medical director for nearly 15 years of the Center for Integrative Health and Healing, a medical director of the Respiratory Care Department at Hartford Hospital, and delivered integrative medicine to floor and ICU patients for decades. So she truly comes with just such an incredible wealth of experience and information, especially around this current topic. She's a recipient of numerous teaching awards, authored many scientific articles and abstracts, as well as done a lot of integrative medicine research. In 2017, she became the Fellowship Director here at the Academy of Integrative Health and Medicine, and we could not be happier to have her. She currently lives in Sedona, Arizona, where she practices integrative pulmonary medicine on a part-time basis. So we're really excited to introduce Dr. Cappelluti and hear from her about pulmonary medicine in a time of COVID.
Thanks, Tabby. Happy Friday to all, and thanks for joining us. Coming to you from sunny Sedona, beautiful here. And I'm going to talk to you today a little bit about coronavirus, and then shift gears a little bit and talk more generally about lung wellness. And, you know, in deciding to, talk about coronavirus again, I mean, at the risk of, all of us feeling somewhat waterlogged from this whole topic, I mean, it's really just been so consuming, over the past weeks and months. It still is a topic that people have tremendous interest in and questions about. And if you'll indulge me, my plan here is to provide perhaps a slightly different perspective, one through the lens of the pulmonologist and the intensivist, because it is, different depending, where you're actually encountering, folks that are potentially infected with this. And then we'll shift to lighter topics towards the second half of the presentation and, kind of go back a little bit and talk about the lung from a worldview and whole health system approach. And then talk specifically about some things that you can do for, your general lung health. And I'll mention a few, common lung diseases at that point in time. So let's start with COVID-19. And, you know, just to remind you, I mean, some of this will certainly be review. Coronaviruses are enveloped, they're positive sense single-stranded RNA viruses, about 30 kilobases in size. They infect a variety of different host species. And from a classification perspective, there are generally 4 genera: alpha, beta, gamma, and delta. The alpha and beta coronaviruses infect primarily mammals. And specifically, the human coronaviruses, 229E and NL63, which belong to the alpha genus, cause common cold and croup, which we encounter all the time. The beta coronaviruses, the SARS-CoV, and then the Middle East Respiratory Syndrome coronavirus, as well as SARS-CoV-2, belong to a different genus, the beta genus. And the current coronavirus virus that we're dealing with was classified as a SARS-CoV-2 because it shares 80% homology with the original SARS-CoV virus that caused acute respiratory distress syndrome with pretty significant mortality rates back just in the early 2000s, 2002, 2003. The life cycle consists of basically 5 different steps: attachment, penetration, biosynthesis, maturation, and release. And that's illustrated here, where you have virus particle entering via either membrane fusion or endocytosis into the cell, binding here to the angiotensin converting enzyme 2 receptor, for which it has strong affinity. When it enters into the cell, penetration, you have release of the genome, and then a series of steps to basically transcribe the different components needed to assemble more viral particles, because that's really the goal of this virus, right, is to replicate and do as much damage as possible. And so the 4 different component parts, nucleocapsid, the spike proteins, membrane, and envelope proteins, are then translated. This would be the biosynthesis part and maturation part, using the host cell endoreticulum. And then assembly of the viral particles take place, and then they're finally sent back out of the cell via exocytosis. So this is the life cycle. We know that angiotensin 2 or ACE2 are functional receptors for this virus. We also know that this particular receptor is expressed in very high levels in lung, heart, ileum, kidney, and bladder. In the lung, these receptors are expressed very highly on the epithelial cells that line the respiratory tract. But what we don't yet know is whether or not there are other target sites in the lung to which this virus can bind. Now, if you look at the pathogenesis, it can be broken down basically into 3 different stages. The first stage would be considered the asymptomatic state. And you probably hear a lot about this. It certainly has been a focus in the news for weeks now about folks being asymptomatic and still being able to spread the virus. This may be somewhere between the first 1 or 2 days to as long as a week, or maybe even longer. We're not entirely sure. And during that period, the nasal swab would be positive. During this time, the virus binds to epithelial cells that are in the sinus cavity, and breathing about 22,000 times in a 24-hour period gives the virus great opportunity, to enter the upper respiratory tract. The second stage, stage 2, would be what's considered the upper airway or conducting airway response. And this occurs over the next several days. And this is when people will begin to develop some clinical symptoms. You would, again, continue to have a positive nasal swab. You would begin to see some early markers of immune activation. And during this time, the virus propagates and migrates down the respiratory tract along the conducting airways, and the host begins to mount a more robust immune response. Now, the majority of people, like 80% of people, will probably not progress any further than that. Self-limited course, they'll get better over time, can be managed at home. It's the 20%, the remaining 20% that progress to stage 3. And this is characterized by hypoxemia, ground glass opacities on chest x-ray and CT, which I'll show you momentarily, and fulminant ARDS, acute respiratory distress syndrome. This can occur, a couple of weeks, 1 to 2 weeks after the initial infection, and is clinically characterized by severe shortness of breath, hypoxic respiratory failure, and potentially multi-organ dysfunction syndrome. And at this point, from a microscopic cellular perspective, the virus has now reached the alveoli. It infects the type 2 pneumocytes, which line the alveoli. It can lead to cellular death through apoptosis, diffuse alveolar damage, fibrin and hyaline formation, all of which are characteristics of acute respiratory distress syndrome. And I'll show you a really great picture in a few moments that illustrates this. And you can also have microscopic thrombotic events that can occur here. And this can lead to other complications, including pulmonary embolism and stroke, which we see at higher rates in these folks that are infected with COVID-19. So here's an electron micrograph. These are type 2 pneumocytes that have been cultured in vitro and infected with the coronavirus. And you can see the little virus particles here in the vesicles of the pneumocyte, and you can also see them here at the apical membrane where you have the microvilli here projection. But these are all virus particles here. We know clinically folks, most commonly present with shortness of breath, fever, and then there are a myriad of other things that, they can demonstrate. They can ultimately develop pneumonia, septic shock, kidney failure, sometimes requiring transient hemodialysis, and there can also be an array of GI symptoms too. And I put this slide in here because I think this is really helpful to compare symptoms of coronavirus to other common respiratory ailments. And as a pulmonologist, certainly the number of people that I see who have shortness of breath is quite high. And so trying to discern the folks that really need a coronavirus test from those who do not can sometimes be a little tricky. This slide I think can help, help one to discern, certainly common things, as I mentioned, shortness of breath, fever, cough. You don't tend to have shortness of breath with the common cold or the flu for that matter. So, this can be just used as reference for those of you that might encounter folks with potential coronavirus symptoms. Now, there's also been, a lot of questions, things in the news and also just in the medical community about how coronavirus may affect children differently. And I know that there's a whole separate entity now, a respiratory illness that, some children have succumbed to that may be related to this. But generally speaking, a lot of pediatric patients tend to have milder symptoms compared to those who are much older. And, there has been some research done both out of Italy and China that suggests the severity of the virus may be related to viral loads or to the amount of infectious exposure. And children are thought to have less viral loads, and that could be due to a couple of different things. And these are some of the things that have been hypothesized, that the expression of the ACE2 may differ between adults and children, and that children may qualitatively have a different response to coronavirus than adults. You frequently hear the reference to cytokine storm that occurs in adults. Well, it may actually be more like a cytokine sprinkle or a cytokine drizzle rather that occurs in children. Diagnosis, I'm not going to spend a lot of time on this because this, could probably be a separate topic in itself, but once infected, After antigen presentation, we have both cellular activation of cellular and humoral immunity. And, we're doing regularly now rapid PCR tests, some ELISA testing, and ultimately antibody testing, of course, is going to be very important, particularly as folks are getting back out into the public sphere, to really understand, who has actually had infection already. And, as you probably have heard, a lot of folks now think that, people were being infected as early as January and February of this year, maybe even sooner, and didn't really, realize what they had. Okay, the next couple of slides, just to show you some radiographs, and this can be a fairly fulminant process in a short period of time. So this was actually a gentleman who came in with essentially a normal chest x-ray. He has a pacemaker up here, and after 4 hours had bilateral consolidations and had to be intubated and put on mechanical ventilation for acute respiratory failure as a result of coronavirus. When you look at CT scans, and these are just some representative slices, you can see these gray patches that exist. All of these represent what we call ground glass opacities, and that's a radiographic term. It doesn't necessarily give you a clinical diagnosis. That has to be made, with the history. But normal lungs should look something like this. And then all of these lighter gray areas represent ground glass opacity, which in this particular case is related to the coronavirus. Generally, what this represents from a physiologic perspective is an alveolar filling process. And alveoli can be filled with any number of things. Blood, pus, water are the most common. In this case, it would probably be mostly fluid and to some extent, a version of pus, if you would. For those people that have frank hemoptysis, when presenting with this, obviously there'd be some degree of blood in the alveoli. These representative slices are from early phase infection. Later, you can see, clearly advancement of the process. Now we have more consolidation. These areas appear whiter. You can see some stranding here as evidenced at the yellow arrow. This may ultimately become some residual scar tissue that remains and can have an impact subsequently on not only degree of breathlessness, but also on pulmonary function tests. Down here, the green arrow depicts a representative area of bronchiectasis, which is dilation of the airway that can ensue. But, you can definitely see more consolidation, and it's not really a stretch to appreciate why these folks require higher levels of oxygen. So the early stage, the first few days on CAT scan, we see some of this ground glass stuff, something called crazy paving, which look like railroad tracks in the lungs. And then you see more of that with time, the denser consolidations. And if patients recover, then you'll see gradual resolution of that over days. Now, it may take up to several months for that CT scan to resolve completely. And this slide is really a great one. It's been around for 20 years, and I use this so many times when teaching residents and students about the pathophysiology of ARDS, which can result as because of a number of different things. ARDS is more of a microbiologic or a microscopic classification, if you will, and there are clinical aspects of it and definitions that we use as pulmonologists and intensivists. But even if you don't get hung up in all of the writing on the slide and just kind of let your eyes just softly gaze at this, which many of you might be doing anyway, you can tell that the normal alveolus has a lot more empty space here, okay? This is not nearly as busy as this side here. And this interface here, the alveolar capillary interface, is where gas exchange takes place. And this is our type 2 cell, which is the target of coronavirus. On this side, when we have the development of ARDS, we have a multitude of pro-inflammatory cytokines and other mediators, things like interleukins, tumor necrosis factor alpha. And when all of these things are activated, they get pretty busy and they lay down that hyaline that I referenced earlier. They also can play a role in the development of fibrin, which can lead to scar tissue. They destroy the surfactant that lives here and is responsible for keeping these alveoli open and participating in gas exchange. When you lose surfactant, those alveoli collapse and they become atelectatic is the word that we use, or atelectasis that can be seen on x-rays and CT scans. But you can also see that the interstitial space here can fill up with fluid and particulate matter, and then we get leaky capillaries. And that can worsen the development of interstitial edema here. The other thing that can happen in ARDS is that all of these factors are not confined to the lungs. If you think about the fact that you have a heart that's pumping 3 to 5 liters per minute and sometimes more when you have distributive shock, all of these factors can be circulated throughout the bloodstream and can have more distal and distant impact in kidneys and in other organs. So it's not necessarily a process that is confined to the lungs. So as I said, the majority of these patients will have mild symptoms that can be managed conservatively at home. There is somewhat of a spectrum, even within hospitalized patients. And recently, and I think the thing to understand about this, and I think most people are aware, is that a lot of this is unfolding in real time. We have researchers who are desperately trying to publish studies about the best way to manage folks that are in the hospital or not in the hospital. And it's very likely that some of these recommendations may change over time. The American Thoracic Society, which is one of the important, groups for lung docs and thoracic surgeons, recently put together an international task force and tried to come up with some consensus recommendations. And I'm just going to show you a few of these things here and highlight. Again, this task force was charged with trying to recommend, best practices, in the current climate. They were, asked to look at different drugs and, different interventions that can be applied. And so for those that might have developed coronavirus with severe pneumonia, the role of hydroxychloroquine was definitely favored, okay? And so 73% of the folks said, yeah, it probably is a good idea. Prone ventilation, which I'll talk about momentarily, the majority of folks said, yes, definitely prone these people when they're on ventilators because it can improve oxygenation. The role for ECMO, which is extracorporeal membrane oxygenation, the majority would be in favor of that, but this is tricky because it's a resource-heavy modality, and one of the really challenging things about this disease is how infectious it is, how contagious it is, and the lengths to which one has to go to not only protect people, but also to sterilize equipment. So that becomes very labor intensive when you're talking about something like ECMO equipment. Let's see, next one, these were some other interventions. Hydroxychloroquine for outpatients, generally, most people said no, not a good idea. Remdesivir, which has gotten a lot of press lately. For folks that have coronavirus pneumonia, yes, the majority said probably a good idea to use remdesivir. And then a couple of other things. I'll mention systemic corticosteroids down here. Again, 2/3 in this task force said not a good idea to treat with steroids, just for coronavirus, but if they have coexisting conditions like asthma and COPD, and you think that the steroids may benefit that aspect of the person's disease process, then yes, it's probably a good idea. Now, these next few slides may appear a little bit daunting. This is through the eyes of the intensivists now. And, you know, what I would say generally about this is that the way that these patients are treated is not all that different from other people who come in who are critically ill with hypoxic respiratory failure and who wind up on ventilators. There are a couple of differences, and one of the most important things, again, that I just mentioned is about protecting the staff, and then about the equipment. So these are some of the recommendations, you know, when the patient does wind up in the intensive care unit. And one of the things, you know, these are baseline, you know, tests that we would ordinarily perform in any critically ill patient, the usual, you know, serum studies and urinalyses, radiographs. One of the things that I will point out is that bronchoscopy is generally not recommended in these folks, and that's because you want to try to minimize any aerosolization of this virus, you know, whenever possible. And for that reason, you know, when you begin to talk about the need for intubation and whether you try a form of non-invasive ventilation first, that too has been met with some concern because there is some increased risk of creating more aerosol when you use something like a BiPAP or a CPAP machine. Getting proper vascular access, because if these folks do wind up in shock and they need to be given vasopressors, you need to have central venous access. The tendency is to be a little bit more conservative when administering IV fluids, because too much fluid can worsen the respiratory failure because of the ARDS. Nebulizer treatments are for those that ordinarily would need them, like the folks that have COPD and underlying asthma. And then, you know, the decision to intubate, again, is the same as it would be in, you know, somebody that came in for, say, respiratory failure due to influenza virus or a community-acquired pneumonia. I mean, you know, when people are using accessory muscles, when their oxygen saturations, you know, levels drop, when their pH starts to drop because their CO2 is going up, and so not only are they hypoxic, but they are hypercapnic. And you know, once we intubate them, and there's a whole process that the anesthesiologist must follow when intubating these patients, you know, then you have to decide what ventilator settings to put them on. And, you know, generally speaking, again, we want to always ventilate to protect the lung. We don't want to cause any additional ventilator-induced lung injury, which can prolong their course and even worsen outcomes. Proning, when you have the patient literally face down in the bed, or if you happen to have access to a proning bed, which you basically strap the patient into the bed and the patient rotates. The bed actually rotates, much like a rotisserie. You can actually prone the patient for several hours during the course of the day, and I'll talk about that in a second here. So this question actually came up even before you know, I started this webinar, and there are really sort of two aspects of this, and they're pretty easy to understand. When you think about our general anatomy, the majority of the lung tissue is located posteriorly. It's located in the back or in the dorsal aspect, if you want to use the terminology here in the figure. So this is a person laying on their back. The majority of the lung tissue is located here in the dorsal area. And so gravity tends to drive the fluid down. And so if a lot of your lung tissue is located posteriorly and is now filling up with fluid, your oxygen level is going to be a lot lower. Your need for oxygen, higher levels of oxygen will go up. And in addition to that aspect of this, what also happens is those little alveoli, like I showed you a couple slides back, they tend to get more stretched out, the ones that are located up here near the ventral area, and the ones that are in the dorsal area tend to collapse more. And there's this, you know, disparate level of oxygenation, if you will. These alveoli that are stretched out and look a little bit more like balloons are now going to be at higher risk for rupture, something that we call barotrauma or volutrauma. When you flip the person over so that they are now face down, you free up more of that lung tissue. And so now, as fluid settles, it settles into less of the tissue. You free up more of the alveoli to participate in gas exchange. And there's a bit more of an equalization of the dorsal and ventral alveoli now. And so you're less likely to have de-recruited, i.e. collapsed alveoli, like up here. You're less likely to have that occur in the prone position, and you're less likely to rupture alveoli now because you're not distending them as much when they're in supine position. Now, we've been proning people in the intensive care units for probably about 30 years. And 70% of folks will have an improvement in their oxygenation by proning. But the one thing that we were never able to demonstrate was whether there was an improvement in mortality. Until recently, there have been a number of studies, larger studies that have come out. Provera is one of them, which actually shows a mortality benefit in patients that have been subjected to proning. So it's definitely something that most pulmonologists will do. It can be challenging from a staffing perspective. It can be challenging for the nurses because you think about IV access and you think about circumstances in which somebody might actually have a cardiac arrest, what you have to do to then get them in a position where now you can deliver effective CPR. So certainly not without its risks. Quickly here on pharmacotherapy, you know, if you think that they have a co-infection, a bacterial pneumonia, then you would certainly consider empiric antibiotics. If, you know, possible, and you can do some COVID-specific therapies, if the patients seem like they're good candidates, then yes, as I said, the majority of folks on that ATS task force suggested that those be implemented. And steroids, as I said, not generally advised unless they have underlying asthma or COPD or another condition in, you know, where they would benefit from the steroid administration. And then as far as their outpatient medications, you know, you usually will keep them on medications that they were using coming in. The Tylenol is the preferred antipyretic medication, and there's really no evidence to stop, you know, their ACE or ARB medications unless, of course, they're hypotensive. Unfortunately, however, despite, you know, our best measures, the majority of these mechanically ventilated patients with coronavirus will die. And two recent studies, one in Lancet and one in the Lancet Respiratory Medicine Journal, show that that mortality rate is pretty darn high, 81 to 97%. And I will tell you that generally speaking, people who wind up in the intensive care unit and develop ARDS from a variety of different other causes, I mean, the most common being sepsis, but due to a number of different things, we have gotten so good at managing that the mortality rate for ARDS is now as low as 20 to 40%. Used to be 40 to 60%. Now it's 20 to 40%. So clearly nearly double in these patients that develop ARDS as a result of coronavirus. Okay, so everybody take a deep breath. This is kind of the midway mark. We're gonna let go of all this heavy stuff. One hand on your heart, one hand on your belly. Big breath in through your nose and out through your mouth. And in respiratory parlance, we tell our patients to smell the roses and blow out the candles. And that actually helps them breathe a little bit better. Okay. So if we go back historically and just sort of look at the lung from a worldview, you know, the breath is believed to be manifestation of spirit. It's the energetic force that gives us life from the moment we first take our breath. It's what animates us. And when we breathe our last breath, we are said to expire. And it's referred to a number of different things: Qi in Chinese, prana in India, lung, ruach, pneuma, depending upon which world system you look at. And if you explore the sort of the origins in traditional Chinese medicine, of course, it's all about the yin and the yang, and the lung is considered a yin organ, paired, interestingly, and this is a bit of foreshadowing, with the large intestine, considered a yang organ. And disease, of course, occurs when you have an imbalance between the two. Yin corresponds to inhalation and yang exhalation. When you have excessive yin, you tend to have chills, more shallow breath, and might be a little bit more lethargic. And in contrast, excessive yang, you tend to be more heated, have fever and sweats. There's breath work that invokes 6 exhalations, and in traditional Chinese medicine, we implement acupuncture, herbal remedies, and tinctures. We do pulse and tongue diagnoses, and of course, movement is really important, and I'll talk about that a little bit later. In Ayurveda, prana is the life force energy, and prana has 5 different functions. Each has a different type of energy, and breath work also helps enhance all forms of prana. Many of you are probably familiar with alternate nostril breathing, which helps balance the apana, calming, and the prana, or energizing breaths. And yoga is a very important part of Ayurveda, and again, I'll talk about that momentarily. Diet as well, in all of these world systems is extremely important, and we'll talk about that too. Again, from the traditional Chinese perspective, dyspnea and COPD patients, for instance, can be related to depletion of fluids, some lung qi vacuity, and insufficiency of the kidney origin as well. Acupoints that might be exploited related to the lungs and large intestine, also on the spleen and bladder channels. Those can be selected to help relieve shortness of breath. The lung transport and celestial chimney acupoints can help decrease airway resistance, which tends to be elevated in asthmatics in particular, and it also can help folks that have chronic cough. Let's see, the great hammer acupoints diffuse the lung and can help sort of reduce cough, and fish border acupoints can help relieve dyspnea pretty quickly when those points are accessed. I put this in just as a reference. It's kind of a great summary of what you can do when you have certain syndromes. Again, in traditional Chinese medicine, excessive heat in the lung, these are the symptoms that you might have, and these are some of the healing foods that you might want to use. When you have too much phlegm, some of the foods here to help decrease phlegm production, lung qi deficiency, and then lung yin deficiency. So I'm just gonna up through that. And generally speaking, when we talk about lung wellness and lung health, these recommendations are probably going to sound pretty familiar. I mean, what we recommend for lung health is not really different in integrative medicine and health that we would recommend for so many other things, just for general wellness. Lifestyle is important, the environment in which we choose to live. If you're living in a toxic environment, both externally and internally can have a huge, impact on how we feel and the disease that we manifest. Diet and exercise are of utmost importance. Mind-body therapies can be so beneficial when you have, lung issues, breathing exercises, yoga, meditation, and I'll show you some data from this as we move forward. Supplements, can be very important. There's probably not as robust data for that around different lung issues, but I'll show you a little bit of what there is. And I know Mary Hardy spoke last week a lot about supplements and immune support. And one thing I will say is that sinus health is really very important. If you don't take care of what goes on up in the upper respiratory tract and up in the sinuses, that can definitely have a pretty significant influence on what goes on in the lower respiratory tract. And for my folks with asthma and COPD, if they have chronic rhinosinus issues, I definitely spend time, trying to address those things. Diet can play a role there. I mean, many of you probably know from anecdotal experience, and there is some research to support this, that dairy products tend to cause people develop more phlegm and more mucus. And as soon as they eliminate dairy, their sinuses clear up. I tend to recommend salt water nasal rinses. Some people like a neti pot. Others, will use, a squeeze type bottle, and there are more sophisticated devices out there that are marketed now. But sinus health is really important and can't be undermined. But generally speaking, like so many things, the goal is to reduce and prevent inflammation, as much as possible, because that is often, the final common pathway to so many symptoms and chronic disease development. And then also along the way, we want to support the immune system in as many ways as we can. Now, as it turns out, and I don't know how many of you know this, there is a lung microbiome. And it's a fairly nascent field of study. Interestingly, back in 2007, when the Human Microbiome Project was first initiated, the lungs were overlooked as an organ of consideration. And the reason for that, as you might suspect, is because people thought that the lungs were largely sterile. And that was what I was taught when I was a fellow, that the lungs were a sterile organism. And we went to great lengths when we did bronchoscopy and all of that to make sure that we used sterile technique. And that should still be implemented. But as it turns out, there is an entire microbiologic environment in the lungs. And in healthy lungs here, you can see there's a generally low microbial density. And in the disease state, there tends to be higher number of microbes. There are not a lot of studies that have been done in this. In the last 10 years, I think probably only 1,800 studies, and a lot of them have been in animal models, murine models in particular. So there are a lot of disturbances in the microbiome that can influence a variety of different lung diseases. And a lot of the research has been done looking at what happens in folks that have COPD or have asthma. And the microbiome in the lung can be influenced by diet, just as the microbiome in the gut can. And as it turns out, lung and gut homeostasis are intimately linked. The natural next question might be, can probiotics be used to support lung health? And the answer is probably yes. So pulmonologists probably had some degree of gut envy and went on the hunt for this. And yes, Virginia, there is a gut-lung axis too. It is a topic of great research and great excitement in the pulmonary community, because there clearly is a bidirectional influence that the gut has on the lungs and vice versa. So things that can happen in the lungs can influence what happens in the gut. So I should be careful. It's mostly animal models, as I said, but if you infect a mouse, for instance, with influenza, you find perturbations in the microbacteria, microbiotics, if you will, in the gut. And likewise, when you impact your gut, that can predispose you to the development of certain lung diseases like asthma and COPD. So again, there's still a tremendous amount of work that needs to be done in this field. There haven't been a lot of human studies that have been done. It is a little bit challenging when you try to access the lower airways and make sure that you don't contaminate on the way down. That's been one of the largest barriers to doing human studies here. Okay, so when we talk about other integrative therapies that can promote lung wellness, environment, as I mentioned, nutrition, exercise, really important. And if you consider some of the disease states, and that's where you're going to see a lot of the research being done. When you look at asthmatics and you look at folks that have COPD, a lot of what has been published in the research is around how we can influence those disease states. So are there integrative things that we can do to help these conditions? The answer is absolutely yes. Does it stand to reason that those same things can be applied to the normal lung, to healthy people, to help keep them healthy? Absolutely. So you want to minimize potential triggers if your airways are sensitive, if you have asthma. Diet, again, so important. I mean, we talk about food as medicine, right? You hear that all the time. The diet clearly influences in so many ways. What we put in, can be so inflammatory, or we can choose, an anti-inflammatory diet. We know that now that it affects not just our gut, but our lung microbiomes. And, the impact on our immune system. And, we want to favor more lactobacillus and bifidobacteria, less Clostridia, less enterococci. And as it turns out, you tend to see more of those organisms, Clostridia and others, when you have disease states like COPD and asthma and cystic fibrosis sometimes. Exercise, really important, favors the parasympathetic nervous system. We know it has impact on telomerase and what that does for aging. So, really good in just also, maintaining, general lung wellness. Supplements, as I mentioned, probably the biggest player here is vitamin D. I think the most studies have been done looking at vitamin D and its impact on lung disease and lung health. There have been some studies that suggest, some low dose of vitamin C, may reduce the production of some pro-inflammatory mediators. Leukotrienes are, an intimate part of asthma severity and symptoms. Vitamin E has also been looked at, but less so. And magnesium, as you know, can be used in the treatment of acute asthma attacks. A lot of times, IV magnesium will be given in the emergency department when people are in crisis and they have an asthma exacerbation or status asthmaticus. And fish oils are generally good as anti-inflammatory agents. There's definitely data to show support for that. Vitamin D decreases atopy, viral infections. It improves steroid responsiveness and can, in young people, help with lung maturity. So in that regard, has an impact on lung health and wellness. And for the asthmatic, can decrease asthma morbidity. Acupuncture, there have been a number of studies done looking at folks that have asthma and COPD, and we find that basically across, most of those populations, acupuncture improves their health-related quality of life. When they take surveys, they generally all feel better. Some of their dyspnea scores improve after acupuncture, and we can see some improvement in the objective measures such as spirometry and a 6-minute walk test. Again, acupuncture just can reduce stress. It favors parasympathetic nervous system, and just it promotes a more anti-inflammatory state. There's some evidence that biomechanical approaches can add some value: massage, osteopathy, and chiropractic. Let's see next, and then yoga. I mean, there's a lot of data. There's a growing amount of research publications about the health benefits of yoga, not just for lungs, but for so many things. Yoga is part of pretty much every pulmonary rehab program. And I love this slide from JACM 10 years ago, but here at the top you have stress, and then you have all this stuff, and then you have disease. And yoga can have a significant impact on a lot of this stuff. Okay, so I'm not going to say any more than that. There have been a lot of studies that have been done looking at, the benefits, physiologic benefits, subjective benefits, epigenetic benefits. There have been some great studies done by Denninger and others up in Boston about the epigenetic effects of an 8-week yoga program. It can reduce just anxiety and improve depression, and it does all kinds of great things for blood pressure and heart rate, for dyspnea scores. So just generally speaking, it's a great thing to do. And for a lot of my patients, if it's something that they enjoy, I encourage them, to do it. The breath work is really important. And some of the postures, if they're able, and they can do chair yoga, they don't have to necessarily get down on a mat and make it too complicated. A couple of other studies that have come out, yoga for 3 months improved a lot of spirometric parameters, also improved blood pressure and heart rate. That shouldn't come as a surprise to anybody. And this is one of my favorites from Chest Physician about 5 years ago. COPD patients who were randomized to a 12-week yoga program had improvements pretty much similar to patients who were randomized to a standard pulmonary rehab program. That's pretty impressive. The difference is that insurance companies don't yet universally pay for yoga programs while they do pay for pulmonary rehab. Other things that are really great, movement that I mentioned earlier, guided imagery, hypnosis, mindfulness practices can be really important for reducing inflammation, just improving outlook. And we know that a positive outlook can really influence our biology and our microenvironment that lives within us. Biofield practices, even just having a practice of gratitude every day, where you are grateful for every breath that you take. I have a little sticker on my at my desk at home that says every breath is a gift, and it is the truth. I mean, without the breath, where would we be? Social support, both our online communities now and our in-person communities play a role. And for lung therapy, singing is a great thing. It helps open up all of those atelectatic lung units. So, in the last couple slides here, again, in the end, it's about preventing inflammation in any way that we can, diet, exercise, some of the supplements that I mentioned, supporting the immune system, finding those things that really bring joy to your life, things that make your heart sing, things that provide food for your soul are so important in helping us stay healthy from a physical perspective. And not only do those things support your lung health, they will help protect you from coronavirus. And in the end, it all comes down to the breath. And so with that, I will stop. I have a couple of references here. And Tabby, I don't know if you want me to scroll through some of the other things or if you want to wait on those last couple of slides.
Yeah, why don't we just stop the screen share for a few minutes and then we can bring those back up and just take some questions right now.
Okay.
Great. So let me get to the Q&A.
I'm just going to take a drink here.
So first of all, Erika, that was just a really amazing. Sorry, I really appreciate that presentation. I feel it was just such a great review and helped me rethink about a few different aspects of this. So thank you so much. I really appreciated it. So we have a question from Lena Bautista. She says, when giving antibiotics for bacterial PNA, she's doing outpatient telehealth. Do you get a chest x-ray? What if unilateral at the time you get it, but it's on its way to progress bilateral, like COVID usually does? Would you then redo it, or what's your approach to that type of scenario?
So if if you think it's bacterial and you begin the process of treating with antibiotics, and again, this is if in the outpatient setting, I would assume if the patient does not respond clinically, like they don't have improvement after the next couple of days, or in fact, their symptoms begin to worsen, then I would repeat a chest x-ray at that point, and I would, consider a number of different things. And this holds true whether we're in, the time of coronavirus, or even, you know, before this. It's like if you have somebody that you think has a community acquired pneumonia who doesn't respond to your initial therapies, and for that, you know, you're going to target the most common things, you know, atypical pneumonias, and, you know, streptococcal pneumonia. If they don't respond, then, you know, you want to think, okay, well, am I dealing with a non-bacterial phenomenon? Is it a viral pneumonia? Could it be something else? I mean, could they have, you know, acute decompensated heart failure? You know, and in these days of coronavirus, then, you know, sure, absolutely. I mean, I would, you know, want to, you know, if they had fever and if they had other compelling symptoms, then I would, you know, get a COVID test done as soon as possible. And, you know, repeating a chest x-ray with clinical worsening would certainly be appropriate.
Great. Another question is about the steroid and beta agonist inhalers, and how do those affect the lung microbiome? Is there an understanding of that?
You know, I would probably say not explicitly yet, at least in human studies. I mean, is there going to be an impact, you know, on the lung at the alveolar level, at that, you know, what you're considering microbiome level when you take steroids? I mean, we know that steroids reduce inflammation, okay? And we can do and there have been some studies that have been done looking at the impact, say, on steroids in, you know, eosinophilic production in the airways, right? I mean, there is a form of asthma that, you know, is considered eosinophilic asthma, where you have a very, very high level of eosinophils in the airways. And, you know, we know that steroid inhalers can definitely attenuate that response. We can also measure that response now in the office, actually, by using a surrogate measure of fractional exhale of nitric oxide, a FeNO measurement. The beta agonists, of course, are bronchodilators, and those largely work by relaxing the muscles around the airways. Probably less of an influence on the microbiome, you know, than the steroids, but the extent to which steroid actually impacts the resident bacteria that reside in the lungs, I don't think we have any data on that yet. Certainly not in humans. Not sure whether there's anything in the murine model that's been done yet.
Great, thank you.
Mm-hmm.
We have a question coming in from Dr. Patricia Christie. She's asking, what role does remdesivir have now, in your opinion?
You know, again, I think in those people who are critically ill in the intensive care unit, who would be considered candidates for it. And the one thing that I would say is that each of these cases has to be, you know, looked at individually. And, you know, as with anything else in medicine, you know, primum non nocere, we want to make sure that we don't do any harm. And, you know, the advice for so many of these investigational medications is, first of all, you know, you take it, each one on a case-by-case basis. And if you think there is potential benefit and that outweighs the potential risk, then the decision to utilize the remdesivir would probably be one that would, you know, be, you know, called into favor. And so that person would probably be given, you know, the medication. You know, there still are a lot of ongoing studies. I mean, you know, you guys probably remember that initially hydroxychloroquine was thought to be the panacea. And then we found that, you know, well, maybe not so much. You know, there are definitely some, you know, cardiac arrhythmias that ensued, and, you know, some, you know, unforeseen morbidity that resulted. We don't know exactly yet whether the remdesivir will have any, you know, negative sequelae, you know, down the road. So for right now, I would say that, you know, in those critically ill patients who are probably, you know, being considered for the drug, and there is some evidence that there's benefit, and so on a case-by-case basis, you would consider implementing implementing it.
Great, thank you so much. And we are out of time. I really appreciate everyone's questions. Would you mind bringing the slide deck back up? I mean, it's just such a beautiful picture. So thank you for reminding us to breathe. And just to wrap up very quickly, AIHM kind of COVID actions that we are taking here at the Academy. We have transitioned to 100% virtual events. Our annual conference, People Planet Purpose, will be October 9th, 10th, and 11th online. As well as all of our fellowship retreats, graduation, and clinical immersions for the safety of our patients and our communities and our just members. We have moved all AIHM chapters virtually. We are going to continue to provide free CME in our platform for our members. So if you're an AIHM member, remember that we are doing that and you can get some free CME each month. We're offering these 2-time-a-week wellness webinars and Monday morning meditations for 15 minutes on Mondays to bookend our weeks. We have the repository of COVID resources on our website and also the members only COVID discussion group within AIHM's online platform that thankfully is being moderated by Dr. Mary Hardy. And then we're doing monthly AIHM town halls, which will have a variety of expert speakers from the integrative community, and that one will be coming up soon. Next slide. So our next town hall will be on one of these meetings during our Friday wellness webinars, likely in June. Our Monday meditation this week, I'll be doing a quick meditation for 15 minutes on the 18th. Next Friday, we'll have Bradley Jacobs, our past board chair, speaking about similar topics, and we're excited to have him. We'll have the Monday meditation on the 25th, and then on the 29th, Jacqueline Chassie will be discussing how to pivot your practice to telemedicine. So if that is something you're interested in, please mark that on your calendars. So let's stay connected and keep the integrative community together and supporting one another. And we just really look forward to seeing you next time. Thank you so much for coming today and have a wonderful weekend.